Good afternoon, everybody. Welcome to the start of the afternoon session, and thanks to Gareth for giving us the light-hearted task of talking about health inequalities in the context of out-of-hospital cardiac arrest. But as Jason said, you have to play the ball where the monkey drops it, so here we go. I'm going to start with some fun facts. These are taken from the 2022 report from the Ohca group. So the first one is, if you live in the most deprived quintile of socioeconomic deprivation, you are twice as likely to have an out-of-hospital cardiac arrest and 40% less likely to survive than if you live in the most affluent quintile. Number two, men survive Ohca 33% more than women. And number three, if you have a mental health problem and you're admitted post-Ohca, you are less likely to receive cardiovascular interventions or an interventricular defibrillator than if you don't have mental health problems. So that's just to set the scene. I'm going to return to all of that later on. But first of all, health inequalities. What do we mean by health inequalities? And there's some quite interesting words associated with this. So health inequalities are avoidable, unfair, and systematic in the way that they impact on people's health outcomes. So that's a real challenge. You know, they're not just events, dear boy, events, nothing we can do about this. These are avoidable and unfair and systematic. And what sort of things generate inequality and what sort of people are affected by inequalities? So the sort of things would be, you can have inequality in terms of your life expectancy. And we know that rich people live longer than poor people. We know that females in the most affluent quintile live about 8 years longer than the most deprived colleagues, and for men it's worse. It's about 9.5 years. And yet you'll see that there's probably most people have seen the kind of the 6-station bus or train journey from the east end of Glasgow up to Bearsden, you know, where your life expectancy drops off a cliff. So we know that. Access, remote and rural versus urban. And we've seen some amazing work in the first 5 years of the strategy with the Wildcat, and I know there was some discussion about that this morning around where do you place pads. Well, actually, maybe you need a different solution. You have to take the pad to the patient. So there's been work done on that already. Quality of care. I think most people who deliver healthcare would say everybody gets the same level of care. Do we all believe that? Does a well-educated, affluent, white, 40-year-old male get the same quality of care when he goes into hospital than a homeless, substance misusing chap of the same age? Maybe he does. I hope he does. There's some evidence that suggests that's not actually the case. Then there's a few other bits and pieces. There are things that determine your health, such as the quality of your housing. For example, we know that good quality housing is linked to health outcomes. So we think about that then, and we say, right, so what sort of people are then affected? And I've mentioned both rich and poor, people that live in remote rural communities versus urban, and these things can cut in different ways. Individual characteristics, sex, disability, ethnicity, all of these things can have impacts. And then you kind of get to the bit where you can multiply these things together in terms of understanding. And so, for example, a homeless female will have different health needs and risks potentially than a homeless male. And we need to kind of pull all of those things together. And you get things clustered together. So there was quite a few hands up. So who works frontline for SCAS in the room? Right, okay. Who works in the east? Okay, who works in the west? Right, okay. So quite well represented. So we did some analysis of this a few years ago. Looking at deprivation quintiles, the busiest quintile in the West is the most deprived. I don't think anyone would be surprised at that. The busiest quintile in Edinburgh in the East is the least deprived. So what you've got is quite a different makeup of patients that is generating significant parts of your work. All our ambulances look the same. All the guys wear the same uniforms, carry the same kit, work to the same guidelines. But the sort of patients that you're interacting with are different. And we could cut that in different ways when we think about remote and rural or island factors, etc., etc. So that's something to bear in mind. Another thing to bear in mind is what happens when you go and look at this a little bit more deeply. So people in the most deprived communities have fewer GPs per 1,000 patients than in the more affluent ones. They are also less likely to be involved in episodes of elective care than their most affluent citizen colleagues, despite having a greater burden of illness. And that comes back exactly to Gareth's point this morning about the inverse care law. In other words, the people who need the healthcare interventions are less likely to get them than the people who don't. So am I saying that the healthcare system is full of articulate, affluent, middle-class people getting tests for things they're worried about but don't necessarily need? And the answer to that is probably yes, in significant part. And that kind of goes to my point that I was saying earlier around what's the experience of people once they get in to the healthcare system. And there's a question that I don't know the answer to, and that is, what's the experience of our patients when we attend them when they are refracted through these different characteristics? And I'm not saying anyone's doing a bad job. I think in general everyone's doing a fantastic job in difficult circumstances. But given the measurable inequalities that we're seeing, we need to challenge ourselves about how we then respond to these. So if we take this back then to Scotland's out-of-hospital cardiac arrest strategy and think about it like that, as Kylie said correctly, in the relaunch of the strategy in 2021, I think it was, there was a statement there that said we will concentrate our efforts to reduce inequality of outcome for people experiencing OHCA. And I think that's fantastic. And I guess the question now, and what I'd like to talk to you about and get feedback about is, okay, so how are we going to do that, given what we see and where we see it? Because our response times in the more deprived communities in Glasgow are the best in the country. So it's not about getting there quick, or it's not just about getting there quick. So when we think about then the chain of survival, so you've got your preparedness thing, and I'll talk about that in a second. You've got your call for help, you've got your bystander CPR, you've got your defibrillation, you've then got ambulance on scene, and then you've got your aftercare. I think in every bit of that, we need to challenge ourselves about taking an equalities-sensitive approach. So when we think about preparedness, we're thinking about in what way are we enabling the communities that we serve to help us, to help them. So thinking about some really good stuff, Save a Life for Scotland, targeted schools in deprived communities. I think it's a great idea. That in and of itself puts down a marker that actually we're looking at this. As I said before, the wildcat side of things, some very imaginative thinking about how to do something difficult in a place where we knew there were very poor outcomes because of the inability to get a quick response to people when they have a sudden cardiac arrest. But what more can we do? And what more can our ambassadors in these communities, those paramedics who work in stations that serve these communities, do with and for us as an organisation, and with and for the communities, so that we can actually understand that. And one of the things I would like to get in terms of feedback from this is some feedback from you guys on the front line, from managers, from other people working in the service, and from those in organisations aligned to this collegiate effort to say, what about this? What about that? What could we do? There are some really interesting pieces of work going on. There's some fascinating stuff going on in Govan Hill around Glasgow South Station that's just starting to take off. And we're looking at some data sets around what's keeping us busy there, and we've got opportunities to engage with those local communities about what their priorities are, because there's a good chance that our priorities aren't the same as theirs. They live there. We dip in and out. So that's one thing around preparedness. I know Gareth and Shorty could say a lot more about that, but just thinking about it. So how up front are we engaged with the people that we serve in respect to this? And that then takes us on to, okay, well, what are the characteristics of those communities? So, for example, when you call for help, phone 999, brilliant. English isn't your first language. In fact, you've hardly got any English at all. Translation services, probably most of us have heard of Language Line. I'm not criticising Language Line, but it's absolutely fantastic if you've got an appointment with somebody at 10:30 tomorrow morning or this afternoon or whatever, and you need to schedule an interpreter. What if that call comes in and you need someone that can help you understand what that person's saying to you in real time? We're not really equipped to do that. And that's a challenge. And we're in discussion with ACC colleagues about what possibly can we do in those circumstances. It's rare, but it does happen, and it has happened. Bystander CPR, what are the barriers to CPR? Ethnicity, religion, cultural expectations, respect, disrespect, all sorts of different things potentially. But what we're saying is the sooner you can get hands on chest, and I like that question from the paramedic from the Resource Council around what's best, ventilations or hands on or compression only. Yeah, wrong question, and the answer's great. This is what someone in the community can do and be prepared to do until someone else can come and do the next bit. Brilliant, but it's the danger of how you ask the question, isn't it? That's actually what the take-home message from that is. So how do we then take some of that preparedness work and take it into these questions? I'm not going to say a great deal about defibrillators. I thought the rapid sessions were fantastic, and I think you can draw connections between 3, 4 or 5 of those presentations around mapping, around how do we use behavioural factors to affect that pre-shock pause when the defib arrives, etc. So that, there's a real synergy in that space. But what about, I think it was Ben's presentation around the location. So we've got those maps for every local authority, haven't we? And how about we then actually get on the front foot with that even more than we are, and we say, but we want you to prioritise the location of them by SIMD 5. Because that could have a multiplier beneficial effect. But we would need we need capacity to do that, and we need to be pushing at it, and we maybe need to be talking to our police and fire colleagues to do that as well. If we can go as a blue light voice. So ambulance then gets on scene. Do we treat everybody the same in all circumstances? I think we treat everybody to the best of their abilities, what I assume. But are there nuanced factors in terms of resource guidance depending on what's actually led to the arrest, etc.? And are there some inequality-related factors that could fit in there? And I know Shorty's thinking about that because I've asked him about it a few times. But there's something. How do we then bring other teams like our drug harm reduction teams into these kind of conversations as well? And then the final point about the aftercare. One of the research papers in resuscitation, they looked at 32 different papers. One of them was from Denmark, and the implication was that poorer people get poorer care in the hospital setting. Now, that's not a nice message to try and sell, or if it is the case, it's an important thing for us to try and address. Gregor, the Chief Medical Officer, keeps banging on about atlases of variation, and maybe there's something in that space that we need to look at. So, bringing it all back, then, you're more likely to have a cardiac arrest if you're poor and you're less likely to survive. You're more likely to survive if you're a guy, and if you get mental health problems, you might not get optimal care. These are written down, so we're aware of them. I think we are ambitious in our expectation or our determination to get to 15% survival by 2026. And I guess then all the stuff we've been hearing, fantastic presentations this morning about improving outcomes, we also have to balance that with looking at fairness in the system. Because actually, if we can bring these gaps closer together, so we're not looking to make anybody's care worse. If we can bring these gaps purposefully closer together, we will take a big step towards that 15%. So we're all on the same page, we're all pushing for the same outcome, and I think we need to be honest with each other about where we can see areas for improvement in this space, and every bit of our Ohca work plan needs to have that fairness component baked into it. Thank you very much.